A very good morning to all of you. I welcome you all for today's session. I am Dr. Priyanka here, educator on Unacademy, and today I am here to teach you a very important topic from systemic pathology as well as medicine in an integrated manner. That is nephritic and nephrotic syndrome. So this topic is really very important. Just a second. Let me see if I can see your chat. This topic is very important for all exams from MCQ point of view. So whether you are competing any medical entrance exam, NEET, PG, FMG, INI, or next, this topic is really very important. So without wasting time, let me start it, the renal system in an integrated way. So I will cover the important topics of renal system, nephritic syndrome, nephrotic syndrome, the various types of glomerulonephritis from medicine point of view also and from pathology also. So it is a very important topic in both subjects. Okay. Without wasting time, I would like to come on nephritic and nephrotic syndrome. But before that, you should understand the normal anatomy and physiology of renal system. Okay. We know that human have a pair of kidneys. You can see the right kidney and the left kidney. Kidney are bean-shaped paired organs, right? Now, the point where renal artery, renal vein and ureters are entering or exiting from the kidney, that point is known as hilum. So hilum of the kidney is situated at the midpoint on the medial aspect where renal artery, renal vein and ureters are located. You can see, right? At the midpoint on the medial surface, these are located. Now, inside each kidney, there are nephron. Nephron is the structural and functional unit of the kidney. Each kidney have 1 million of nephron. Each kidney have 1 million of the nephron. Please remember, each kidney have nearly, so 2 kidneys have 2 million of the nephron. That is the structural and functional unit of the kidney. You can see the structure of a nephron here. Can you see the structure of a nephron? Nephron have 5 portions. This is known as Bowman's capsule. This is known as proximal convoluted tubule, that is PCT. This is known as loop of Henle. This is known as distal convoluted tubule, DCT, and this is known as collecting duct, CD. Now look at loop of Henle. It has 2 limbs, descending limb, ascending limb. You can see this is descending limb, this is ascending limb. So loop of Henle have 2 limbs. So these are the 5 parts of a nephron. You can see Bowman's capsule. Inside Bowman's capsule, you can notice a tuft of capillaries. It is a tuft of capillaries which is forming the glomerulus. So what is actually glomerulus? Glomerulus is a tuft of capillaries formed by the renal artery. Okay, you can see this is, let me separate this portion. So these are the 5 parts of the nephron. You already got it, right? I have already told you these 5 parts. So the nephron have capsule, Bowman's capsule, PCT, loop of Henle, DCT and collecting ducts. We have already seen it. Okay, I will come on the glomerulus. Now, if I cut the kidney, what are the parts of the kidney? Kidney have 3 portions. The outermost part of the kidney is known as cortex. The inner part of the kidney is known as medulla. And innermost part is known as pelvis. You can see, okay, let me mark. This portion is cortex. Can you see? I'm marking with red. This portion is cortex. It is outermost thin rim. Outermost thin rim. Can you see? It is cortex. It is cortex. The outermost portion is cortex. What does now nephron? Each kidney have nephron now. So which portion of the nephron is present in the cortex? So all the Bowman's capsule and glomerulus are present in cortex only of 100% nephron. All the nephron contains the glomerulus of all nephrons. Cortex, it is present in cortex. Coming on medulla. In the medulla, can you see these pyramids? Okay. Can you notice this pyramidal shaped structures? These are known as renal pyramids. These are known as renal pyramids. So renal pyramids are present and the tip of renal pyramid is opening in pelvis. It is opening in the calyces of pelvis. It is known as, this tip is known as renal papillae. Renal papillae. So can you see? So cortex is there. Cortex is outer rim. It contains all the glomerulus. What about tubules? I will tell you. Okay. Okay. And medulla. Medulla contains multiple pyramids. And the tip of the pyramid is known as papilla. Papilla. So all the urine from the pyramid getting collected in the pyramid, it will be entered in the pelvis via papilla, right? Now understand there are 2 types of nephron. What are the 2 types of nephron? Let me cut this portion of the kidney. Can you see? I am cutting a cortex and a medulla in this way. Can you see this portion of the kidney? Inside it there are 2 nephrons. Can you see? This portion is cortex. This portion is cortex and this portion is medulla. So cortex, this is cortex, you can see, and this is medulla. You can see. Now see this nephron, this nephron, this nephron. Can you see this nephron? The entire nephron, that is glomerulus along with all tubules. This is PCT, loop of Henle, DCT, the entire nephron present in cortex. So this nephron is known as cortical nephron. The entire nephron, that is glomerulus and all the tubules. By tubules, I mean PCT, I mean loop of Henle, I mean DCT and collecting ducts. All the tubules along with glomeruli. Can you see this one? It is present in the cortex. Now see the second nephron. Here, the glomerulus is present in cortex. The remaining tubules are present in cortex, but loop of Henle is going in the medulla. So such nephron in which loop of Henle is going in the medulla, such nephron is known as juxtamedullary nephron. Most of the nephrons, 85% of the nephrons are cortical only. Only 15% of the nephrons are juxtamedullary. Have you got it? So there are, humans have two types of nephron. I would like to draw this diagram for you. Let me draw this diagram for you. For the clarification of the two types of nephron, you can see the above portion is the cortex and below this portion is the medulla. Now let me form a rough diagram of a nephron. So this is the glomerulus, PCT, loop of Henle, DCT and collecting tubule. The entire nephron is in the cortex, right? And see this diagram. This is glomerulus, this is PCT, this is loop of Henle, this is DCT and this is collecting duct. Now you tell me the name of the two types of nephron. This nephron is cortical nephron because the entire nephron is in the cortex. And this nephron is juxtamedullary nephron, in which loop of Henle is going in the medulla. Now, what I am saying, 85% of the nephron are this way and only 15% of the nephron are juxtamedullary. If you notice one thing, it is crystal clear in this diagram that glomerulus of whether cortical or whether juxtamedullary, it lies in the cortex. So can I say 100% of the glomerulus lie in cortex? Yes or no? Now see, you will understand it. You will understand it. Have you got it? So 100% of the glomerulus and 85% of the tubules is present in the cortex, right? Remaining 15% of the tubules are juxtamedullary nephron, in which loop of Henle is going in the medulla. So these are the two type of nephrons. In cortical, all glomeruli and complete tubules are present in cortex only. But in juxtamedullary, nephrons send their loop of Henle into the medulla. So these are the two type of nephron. Medulla we have already seen. We have already seen the medulla, right? Now coming on pelvis. The innermost portion, the yellow portion in this diagram is the pelvis. Can you see? Now pelvis have two portions. These are known as calyces. So count. These are the minor calyces. How many minor calyces I am drawing here? How many minor calyces are there? So there are minor calyces 8 to 18 in number. In this diagram, it is 1, 2, 3, 4, 5, 6, 7. So 8 to 18 minor calyces are present and they all open in major calyces. Major calyces. So these are opening in this. These are opening in this. So these are the major calyces and ultimately it is opening in the ureter. Ultimately. So that is the pelvis. Have you got it? Let me come on glomerulus. Before teaching you the various type of glomerulonephritis and nephritic and nephrotic syndrome, you should understand the structure of glomerulus, without which you cannot understand the various type of syndromes and glomerulonephritis. What is glomerulus? Can you see in this diagram what is glomerulus? Yes, you can see. You will say, ma'am, this is glomerulus. What is actually glomerulus? It is the tuft of capillary. Can you see? This is a tuft of capillary. It is present inside the Bowman's capsule. This tuft of capillary which is present inside the Bowman's capsule is known as glomerulus. Okay, let me draw it for you. Let me draw a Bowman's capsule. So what is a Bowman's capsule? It is a capsulated structure, this one, and it will continue in PCT. It will continue in PCT. It is like this. It is continuing in PCT, loop of Henle, DCT in this manner. So it is continuing here. It is continuing here. Now imagine to form the tuft of capillary, this is the afferent arteriole. It is coming, forming one capillary. There are multiple. I will draw only one for the sake of explanation. And it is exiting out in the form of the efferent arteriole. What I am saying, listen again. This is afferent arteriole coming here, forming a tuft of capillary inside the Bowman's capsule. And efferent arteriole is going out. So afferent is coming and efferent is going. And in between there is a tuft of capillary. Now please understand, it is very difficult. So let me draw this, complete this diagram for you people. Then you will have an understanding of it. Listen what I am saying. So the blood is coming here. The blood is coming inside the afferent arteriole. Whatever substances supposed to be excreted out of the body, they will get filtered here and get collected in this space. This space is known as Bowman's space. This space is known as Bowman's space. They will collect it in Bowman's space, and from here they will go in PCT, they will go in DCT, loop of Hanley collecting duct, and excreted out of the body in the form of the urine. So whatever substances present in the afferent arteriole which are supposed to be excreted out of the body, they are filtered here. So this is known as glomerular filtration membrane. Now please understand what is glomerular filtration membrane. Please understand. So imagine there is a substance. It want to cross. It want to cross from the lumen of the capillary. It want to come in this space, Bowman space. So it has to cross three structures in between. So the first thing, it has to cross the endothelial membrane of the capillary. The first thing, this is endothelium, right? The blue color is the epithelium of the base of the Bowman's capsule. This is epithelium. This is epithelium of the Bowman's capsule, and in between the two there is basement membrane. Let me draw basement membrane in between. So this is basement membrane. So imagine a substance which is present in the lumen of the capillary. Okay, I will draw it in the lumen of the capillary. It want to cross and get excreted and come here in the Bowman space. So it has to cross three structures: endothelium, basement membrane, and epithelium. So basement membrane is at the center. On one side there is endothelium, and this substance will ultimately come here and crosses the all tubules and excreted out of the body in the form of the urine. Now give me a thumbs up if you got this concept. It was a big concept, I told you. If you can understand this concept, you can understand the entire glomerulonephritis. If you can't understand this, you will not understand the chapter head. Have you got it? I have zoomed this version. What actually is happening? Give me a thumbs up, those who are listening. Everyone give me a thumbs up. Everyone give me a thumbs up. Okay. One more thing I would like to. So filtration barrier I have told you. So whatever substances present here, if they want to come here, so they have to cross this membrane, and this membrane have three things: endothelium, epithelium, and basement membrane in between. So this is the same diagram. Can you see? This is afferent arteriole coming here, afferent arteriole forming a tuft of capillary, and efferent arteriole is exiting out. This is efferent arteriole. This is afferent coming, efferent going out, and you can see a tuft of capillary, right? In this tuft of capillary, the substances which want to get excreted, they are going in Bowman's space. So they have to cross three layers. So in the center, this is a capillary now. So what is the diagram of a capillary? In the capillary, there are endothelial cells, number one, and there is basement membrane, number two. So this is endothelial cell of the capillary, you can see, and basement membrane of the capillary. So this is the diagram. Can you see endothelium? Endothelium is drawn by red color. Endothelium is drawn by endothelial cell layer, and basement membrane is drawn by black color. And epithelium, the green is the epithelium. So see a substance here. Imagine, you yourself imagine a substance here. Here is a substance. So it has to cross three things. Number one, the red endothelium. Number two, the black basement membrane. And number three, the green epithelium. And ultimately, the substance will come here and excreted out of the body in the urine. So three things constitute filtration barrier. Have you got it? What are the three things? Endothelial cells on one side, epithelium on other side. This green color epithelium is visceral epithelium. Visceral. Okay, let me draw a Bowman's capsule. This is a Bowman's capsule. Right, this is a Bowman's capsule, right? And what I am saying, this is the blood capillary having endothelial lining. Okay, let me draw a blood capillary for you to explain you it completely. This is blood capillary. Okay, what I am saying, this is afferent arteriole. This is capillary, and this is efferent arteriole. I have told you this. Now this is endothelium. It is very easy to understand endothelium. We all know what is endothelium, and endothelium is resting on basement membrane. So this is basement membrane. You got endothelium, you got basement membrane. Now look at Bowman's capsule. In Bowman's capsule, two types of epithelium are present. This epithelium is visceral. This epithelium is visceral, which I am drawing with purple color. And this epithelium is parietal. This epithelium is parietal, which I am drawing with the black color. So in filtration barrier, it is visceral epithelium which is coming. The visceral one, visceral epithelium is coming in the filtration barrier. The parietal one, this one, the black one, it is present. It is also lining the Bowman's capsule from side. The central layer is drawn, is lined by visceral epithelium. And this is parietal. Parietal is not coming in the filtration barrier. So whatever substance present in the lumen of the capillary, it's supposed to get excreted. So it has to cross three layers. Number one, endothelium of the capillary. Number two, basement membrane of the capillary. And number three, visceral epithelium of the Bowman's capsule. So ultimately it will come here and excreted out of the body in urine. I hope you got it. One more thing I would like to add here. What is the shape of this visceral epithelium? Actually, the shape of this visceral epithelium is in the form of the foot. You know, human foot. Human foot, this is toe and these are the fingers of human foot. You know, foot of a human. Foot of your human. So, foot of human, right? The shape is like foot of a human, right? Can you see here? That's why these are known as podocytes. Podo means foot. Podocytes. That's why these are known as visceral podocytes. See this diagram. So this is endothelium on one side, you can see basement membrane in the center and visceral podocytes on other side. It is not parietal which is coming. It is visceral which is coming. Have you got it? Have you got it? Yes or no? So this is filtration barrier having three things. Endothelial cells, epithelial cells which are known as podocyte, and in the center there is basement membrane. I would like to draw it for you. I would like to draw it for you. So let me draw a basement membrane in the center. This is basement membrane in the center. On one side, it is endothelium, endothelium of the capillary. On other side, it is epithelium. Which visceral or parietal? It is visceral epithelium. Visceral epithelium of the Bowman's capsule. And the shape is like the foot. The shape is like the foot. The shape is like, that's why these are known as podocytes. These are known as podocytes. So whatever substance present here will cross these three layers and come in the Bowman space. Give me a thumbs up. Everyone give me a thumbs up, those who are listening. You got this concept very clearly. So if you got this concept very clearly, this is endothelium. This is now one thing about basement membrane I would like to elaborate here. This is basement membrane and this is epithelium. By epithelium I mean visceral epithelium or podocyte, one and the same thing. Okay, listen, in the basement membrane there are three portions in the basement membrane. The center of the basement membrane is very dark. If you see under electron microscope, it is very dark, and the peripheral two portions of the basement membrane is relatively light. So this is the basement membrane divided into three parts. The central basement membrane is known as lamina densa and the peripheral are known as lamina rara. Have you got it? So basement membrane have three portions. The central lamina densa and lamina rara on both sides, internal and external. So see this diagram. See this diagram. The same diagram I have drawn it for you. So this is the basement membrane. Please appreciate. On one side, please draw the endothelium. Any side you can draw endothelium. On other side, please draw the visceral epithelium, which is in the form of the foot, that is podocytes. So in the basement membrane, appreciate the three layers. The central is the densa and the peripheral are rara. I want thumbs up from everyone. If you got this concept, this is the same diagram on electron microscopy. Appreciate the basement membrane, the two rara on the periphery and one central densa in the center. You can appreciate this densa and appreciate the two rara on both sides of the densa. Give me a thumbs up. You got it? You got it? Okay. If you got it, let me teach you the last diagram from Robbins before coming to the diseases. If I am cutting this glomerulus from here and looking from above, what I will see? I will see this. You will see, ma'am, what it is. Can you see? These are the multiple blood capillaries. There are multiple blood capillaries. I have drawn only one, but there are multiple. 1, 2, 3, 4. 4 are shown here. So please appreciate the blood capillaries. Inside the blood capillaries, can you see an orange colored lining which is fenestrated? Fenestrated means having holes in it. It is endothelium. So capillaries are lined by endothelium. Yes or no? On the other side, can you see these blue colors podocytes, the food processes, the visceral epithelium. So on one side of the capillary, it is endothelium. On other side of the capillary, it is epithelium. And if you zoom out the image between the two, you can see a very thin pink color layer. If you can appreciate this very thin pink or purple color layer, this is the basement membrane. So basement membrane on one side endothelium, on other side epithelium, and basement membrane is at the center. So same diagram. Okay, you got it. Now you tell me, what are these yellow cells shown at the periphery? Can you see this one, this one, this one? What are these yellow cells? Can anyone tell me these yellow cells kaun se hain? You already know. What are these yellow cells? Yellow cells are the parietal epithelium of Bowman's capsule. So this is the Bowman's capsule. Now I have told you in Bowman's capsule two type of epithelium is there. So here the epithelium is visceral and here the epithelium is parietal. So this is the parietal epithelium covering and forming a cup. Have you got it? And what are these green cells? Can you see the green cells? Now there are multiple capillaries. Okay, this is capillary number 1, capillary number 2, capillary number 3, capillary number. There are multiple capillaries. All the capillaries are lined by endothelium, right? So I'm not drawing it in all, but they all are lined by endothelium. After that, there is basement membrane. So this is the basement membrane. This is the basement membrane. And on the outer side, they all are lined by food processes, visceral epithelium. Okay, we got it. We got it. Yes. And entire thing is covered by parietal epithelium. So the yellow ones, one are the parietal epithelium. Yes. So these are the cells of parietal epithelium of the Bowman's capsule covering the entire thing and forming a cup. Now, can you see a space between the capillaries? A dead space between the capillaries. So these the green cells here are known as mesangial cells. These mesangial cells are supporting. These mesangial cells are supporting cells which fill the space between multiple capillaries. Which just fill the space between multiple capillaries. Give me a thumbs up. Have you got it, Rishinika, Ananya, Anyama? Have you got it? Have you got it? So please appreciate these green cells are mesangial cells. Have you got it? So this is the final diagram of a glomerulus in which I am going to teach you all type of glomerulonephritis. So this is the final diagram. I hope you can understand it. Can you see the red color? Capillaries, lumen of the capillaries. It is lined by endothelial cells. Appreciate the endothelial cells. On the outer side, there is podocyte, the visceral podocyte. These are the visceral podocytes. And if you in between the two, where there is very thin basement membrane, which is not appreciated in this diagram. So that is the thing. That is the thing. So this is a diagram of a glomerulus. This is the diagram of a glomerulus in which multiple blood capillaries are there. See the lumens. All of them are lined by endothelial cell on inner side and epithelial cells on outer side. So that was the structure. That was the histological structure. I have told you the anatomy and histology of a glomerulus. If you have understood it, it will be easy for you to understand the complete chapter ahead. Everyone give me a thumbs up. Everyone. There are few MCQ questions based on this portion. So this is the first question. Podocytes are seen in which portion of nephron podocytes are present? Very easy question. Podocytes are seen in Bowman's capsule, or they are seen in PCT, proximal convoluted tubule. They are seen in DCT, or they are seen in collecting duct. Please write your answer in the chat box. Please. Whatever you think, please write your answer in the chat box. It's very easy question. I hope everyone knows it. So yes, Rishinika, absolutely correct. So Bowman's capsule. Rishinika, Bowman's capsule, which lining? Visceral or parietal? Podocytes, visceral epithelium or parietal epithelium? I am giving you two options. So I am making question little bit difficult. So Bowman's capsule, I am giving you two options. Is it visceral epithelium of Bowman's capsule, or is it parietal epithelium of Bowman's capsule, which is labeled as podocyte? I am asking to you, Rishinika. Anyone else who want to answer this? Anyone? Yes, it is visceral. It is visceral epithelium which is labeled as podocyte. Yes, very good, very good. Okay, let me move ahead. In the kidney, there are four types of diseases. The disease which involves the glomerulus are known as glomerulonephritis. The disease which involves after glomerulus, we have four tubules: PCT, loop of Henle, DCT, and collecting duct. These four together are known as tubules. So the disease which involves the tubules is known as tubular diseases, right? And the blood vessel, the afferent arteriole and efferent arteriole, and in between them a tuft of capillaries. The disease which involves the blood vessels is known as renal vasculature disease, right? And the background, the supporting background is known as interstitium. So disease which involves the interstitium. So there are four type of diseases in renal system. The most important among these is glomerulus. I have to teach all, but it is a lengthy system. So I will teach you glomerulonephritis first. But before understanding glomerulonephritis means it is the inflammation of the glomerulus, also known as Bright's disease. Inflammation of the glomerulus, that is known as glomerulonephritis. Okay. Before understanding glomerulonephritis, you should understand what is nephritic and nephrotic syndrome. So let me come on nephritic and nephrotic syndrome. Then I will come on the pathogenesis of glomerulonephritis and various types of glomerulonephritis. Okay. So first you should understand the classification of glomerulonephritis. There are three types of glomerulonephritis. Primary glomerulonephritis, which are actually disease of glomerulus. Secondary glomerulonephritis, in which actual disease is something else, but the kidney or the glomerulus is involved secondarily. And the third one are hereditary glomerulonephritis, in which it is congenital glomerular involvement. So there are three types of glomerulonephritis. In primary, There are basically 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 type of glomerulonephritis are there. Secondary mein there are many, but 2, 3 are important. So I will teach you only 3 from the secondary, but there are many. In hereditary, there are 4. There are 4. So these many glomerulonephritis I have to teach you. Okay, let me enumerate. In the primary, the first one is acute proliferative glomerulonephritis, also known as post-streptococcal glomerulonephritis. So APGN or PSGN it is known as. The second is rapidly progressive glomerulonephritis, RPGN. It is known as RPGN. It is known as RPGN. The third is minimal change glomerulonephritis or minimal change disease which occurs in children. The glomerulonephritis of children. It is known as MCD, minimal change disease. The fourth and fifth come together. It is membranous glomerulonephritis and membranoproliferative glomerulonephritis. So they two come together. So that is membranous and membranoproliferative glomerulonephritis. The next two also come together. What are the next two? It is focal segmental glomerulonephritis and focal segmental glomerulosclerosis. So again these two come together. Focal segmental glomerulonephritis and sclerosis. And after that two more are there. It is IgA nephropathy, Berger's disease, and last one is chronic glomerulonephritis. Count them. They are 9. Please count them. 1, 2, 3, 4, 5, 6, 7, 8, 9. Total 9 primary glomerulonephritis are there. Do you have any doubt? The 9 names are in front of you. So please learn them by their nickname, you can say. So the first one is post-streptococcal glomerulonephritis or acute proliferative glomerulonephritis, one and the same thing. Second is rapidly progressive glomerulonephritis. Then minimal change disease. Then membranous and membranoproliferative come together. Glomerulonephritis. Then next two come together. Focal segmental glomerulonephritis and focal segmental glomerulosclerosis. IgA nephropathy or Berger's disease and chronic. So these are the 9 primary glomerulonephritis. I will ask you to make a comparative table between all 9 and we will fill that table. Right? Okay. Coming on secondary, there are many in secondary, but I prefer to teach 3 which are the most important at your level. You have to, at MBBS level, you should understand. So first, the glomerulonephritis due to SLE. It is known as lupus glomerulonephritis. Lupus glomerulonephritis. That is, it is due to SLE. The second is diabetic nephropathy. The glomerulonephritis which occurs in diabetes nephropathy. And the third one, which is, let me see, lupus ho gaya, diabetes ho gaya, HS purpura or Goodpasture syndrome. So these are important secondary ones. So there in secondary there are many. The main disease is SLE. The main disease is diabetes. The main disease is amyloidosis. The main disease is something else, but it is involving glomerulus secondarily. That's why these are known as secondary glomerulonephritis. Have you got it? The third one are the hereditary. Hereditary means the child, the neonate will have congenital glomerulonephritis. There are 4 types. 4 types of hereditary glomerulonephritis. What are the 4 types? Number 1, Alport disease. The most important Alport disease from which many MCQs come. In Alport disease, actually Alport disease is a syndrome in which multiple things will be there congenitally. Congenital glomerulonephritis is one of them. Right. The second is Fabry disease. The third one is nail patella. And fourth is thin membrane glomerulonephritis. So these are the 4 congenital or hereditary glomerulonephritis. Have you got it? Who will enumerate? So there are 9 primary. There are many secondary, but the important are 2, 3 only. And there are hereditary, 4 hereditary. So you have to study all of them. 9 primary, all 9, and 4 hereditary, all 4. Secondary may the important one 2 or 3 only. So make a comparative table between all and fill it and finish glomerulonephritis once for all. Once for all. You got it? Give me a thumbs up first if you got it. That is the classification of glomerulonephritis. You should learn the classification. Now, before starting the various type of glomerulonephritis, I will start them one by one. I will teach you all. As I am saying, in comparative table, I will teach you all. Don't worry. I will make the table with you. But before that, you should understand what is nephritic and nephrotic syndrome. Because all glomerular disease either will result in nephritic syndrome or will result in nephrotic syndrome. Actually, nephritic and nephrotic syndrome are the clinical terms. These are the clinical syndromes. These are the clinical features or clinical terms you can say in glomerular disease. Now, out of all these glomerular diseases, glomerular nephritis, some of them are resulting in nephritic syndrome and some of them result in nephrotic syndrome. So you will say, ma'am, what does it mean? Nephritic and nephrotic. So I'm explaining you the meaning of nephritic and nephrotic before starting the glomerulonephritis. So you should understand now when I will teach you the first glomerulonephritis APG and I will say it is nephritic. So you will understand what is nephritic. The second I will teach you, I will say this one is nephrotic. MCD is nephrotic. MPGN is nephrotic. This one is nephritic. So you should have a crystal clear concept what is nephritic, what is nephrotic. You should understand one thing that nephritic and nephrotic are not one disease. It is an umbrella term which includes multiple diseases. So there are multiple glomerulonephritis which come under nephritic and there are multiple glomerulonephritis which come under nephrotic. So these are not one disease. They are the syndromes including multiple disease. Have you got it? Now let me start with nephritic first. Nephritic. Then I will come on nephrotic. First give me a thumbs up. Are you getting what I am talking about? Give me a thumbs up if you are getting what I am talking about. Let me see. Yes, I can see. So let me start with nephritic and nephrotic syndrome. So nephritic and nephrotic syndrome, both of them are umbrella terms having multiple glomerular disease inside them. So nephritic syndrome is the syndrome in which patient will come to you having 5 complaints. These are the 5 complaints patient will come to you. The most common complaint patient will say, doctor, I am having blood in my urine. My urine is red. Blood in urine, that is hematuria. The first complaint patient will run to you, doctor, my urine is red. I think it is blood. I'm having blood in my urine. So does I have any disease? Does I have any cancer? What does I have? Why my urine is having blood? So that is hematuria. The first feature here is hematuria. Give me a thumbs up. You will ask the patient to give urine sample in a container and send it to the laboratory for testing. Send it to the laboratory for the testing. So in the laboratory, of course, there is blood. Hematuria to hai hai. In the laboratory, RBCs are present in the blood. But along with that, along with the blood in urine, protein is also present in the urine. Normal human urine don't have protein or a very minute amount of protein. Here, abundant protein is present in urine. That is proteinuria. So, hematuria means blood in urine and proteinuria means protein in urine. So, this patient will have blood in urine. This patient will have protein in urine. The third thing, when you measure the blood pressure of this patient, you will find this patient is hypertensive. The blood pressure is more than 120/80. So you will notice this patient is hypertensive. This patient will also complain of edema over the face especially or any part of the body. The patient will say, doctor, I am having swelling. Whenever I get up in the morning, my face is puffy. My face is swollen and gradually down the day till evening it settled down, and again when I sleep in the morning it is puffy. So it is a typical complaint given by the patient, and especially on the face the edema is around the eyes, periorbital edema. So it is a typical edema which is seen here in nephritic and nephrotic syndrome, right? The next is oliguria. Now gradually the kidney will shut down, kidney will not form urine and patient will not have urine. When 24-hour urine is less than 400 ml, it is known as oliguria. Normal urine, you know, it is 1 to 1.5 liter. 1 to 1.5 liter in one day. Normal human excrete 1 to 1.5 liter of urine in one day. But when the human excrete less than 400 ml of urine in one day, it is known as oliguria because kidney is unable to form urine. Everyone give me a thumbs up first. So these are the, now I will explain you the reason for all these. There are 5 complaints. What are the 5 complaints? So a patient will come to your clinic and the patient will say, doctor, I am having blood in my urine. That is the first complaint given by the patient. That is, patient is having hematuria. Number one. You will ask the patient to give the blood sample in the lab. So you will find out patient also have proteinuria. So blood in the urine and protein, because proteinuria, blood in urine is visible, but protein in urine is not visible, right? So it will be detected on lab report, urine analysis. So hematuria is there, proteinuria is there. Once you measure the blood pressure of this patient, you will find the patient is hypertensive. The patient is having hypertension. That is the third thing you will find. Then the patient also will complain of edema. Doctor, I am having puffiness over the face or edema on any part of the body. It is not necessarily face, right? And last thing, the patient will have oliguria gradually. Very less urine, less than 400 ml of urine during 24 hours. That is oliguria. So these typical 5, the cluster of these 5 complaints is known as nephritic syndrome. It is not nephrotic, it is nephritic. Listen, one by one, listen all 5. So number 1, I have told you hematuria. Due to hematuria, the urine is red in color, that is smoky or slight reddish in color, right? And presence of RBC in the urine is a classical feature of nephritic syndrome. This is absent in nephrotic. Please understand. Proteinuria is also there, but proteinuria is mild. It is not very severe. Small amount of protein. When you will call proteinuria as mild and when you will call proteinuria as severe, what are the guidelines? When the patient will give the urine in a container in the laboratory for testing. So in the laboratory, the people will see how much protein is present. If the protein is less than 3 gram in per 24-hour urine, or it is more than 3 gram per 24-hour urine, so you don't have to, the patient don't have to give urine only in a container. What you will ask the patient? You take a big bucket. Ask the patient to take a big bucket, big container, big bucket or big container, and 24-hour urine excrete in this container only. So collect 24-hour urine. If the patient is starting today at 8 a.m. in the morning till tomorrow 8 a.m. in the morning, collect all the urine throughout 24 hours in this container and send this container to the laboratory. Not a small container, a big bucket, a big container, having whatever amount of urine, 400 ml, 500 ml, 1 liter. So 1.5 liter is the maximum urine. So send that big container in the laboratory. In the laboratory, the doctor, the pathologist will see whether 24-hour urine contain protein less than 3 or more than 3. If it is less than 3, it is known as mild proteinuria. If it is more than 3, it is known as severe. Have you got it? Give me a thumbs up. So that is mild and severe. So here it is mild. Protein will be present. I am not saying no. It is present, but it is less than 3. Less than 3 gram protein per 24-hour urine. Give me a thumbs up if you got it. And which protein? You will ask, ma'am, which protein? Name the protein. So is it always albumin? No, not necessarily. Maybe albumin, maybe globulin, maybe other proteins. So it is non-selective. So many types of protein are present. So it is non-selective. Give me a thumbs up. So patient will have hematuria. Patient will have mild non-selective proteinuria. So don't say only proteinuria now. Because when I talk about nephrotic syndrome, ये nephritic है. Nephrotic में ये mild हो जाएगा severe और ये non-selective हो जाएगा selective. In nephrotic syndrome, only albumin come out. Other protein do not come out. Only albumin, mainly albumin come out and it is severe. More than 3 gram of protein will come out. Give me a thumbs up if you got it. The third thing, the patient will have hypertension. Hypertension will be there. Patient's blood pressure will be more. If you measure the blood pressure, it will be more than 120 by 80. Patient will have edema. Again, the edema is mild. Again, now what is the reason for edema? Why this patient is having edema? Why? Actually, this is kidney. Humans have 2 kidney, right? Humans have 2 kidney. So this is the aorta and this is the renal artery going to the aorta. So whatever sodium and water is present in the blood, that is excreted out of the body by the 2 kidneys in the form of the urine. So urine excretes sodium and water along with the excretory materials, that is creatinine, uric acid and all, right? But if kidneys are failed, I mean kidney have some disease, glomerulonephritis or any disease, because of which kidneys are not very much functional. They are not functional. So they are not excreting sodium and water out of the body. So sodium and water will accumulate in the body and accumulation of sodium and water is leading to edema. So reason for edema is sodium water retention in the body. Give me a thumbs up. That is the reason for edema here in nephritic syndrome. In nephrotic syndrome also we will have edema, but the reason will be different. And last thing is oliguria. If the kidneys are involved, kidney are not excreting urine. So patient will have less urine, that is less than 400 ml per 24 hour. So that's why the sodium and water is accumulated in the urine. So that is patient is having oliguria. Give me a thumbs up. Now, the 5 symptoms are crystal clear to you. Let me summarize the nephritic syndrome. Who will help me? Nephritic syndrome. What are the 5 features? Rishinika, Sweetie, Anyama, anyone want to enumerate? What are the 5 features of nephritic? 1, 2, 3, 4, 5. Tell me 1, 2, 3, 4, 5. That's it. Define nephritic syndrome. Define nephritic syndrome. Who will help me? What is the first finding in nephritic syndrome? It is hematuria. Hematuria. What is the second finding? It is proteinuria. But please write down in the bracket, it is mild and it is non-selective. Please write down. Please be clear. Very good, Rishinika. Very good, Sweetie. Yes. Proteinuria, but complete proteinuria, right? Both of you. The third is hypertension. Very good. It is mild. The fourth is edema. What is the reason for edema? Edema, it is sodium and water retention. Sodium and water retention in the body because kidneys are non-functional. And fifth one is oliguria. Yes, edema and oliguria. Rishinika, very good. Very good. So it is oliguria. So these 5 features together constitute nephritic. Now compare with all their 5 with nephrotic also. I will tell you. But now, before coming to the nephrotic, you tell me how many. I have told you glomerulonephritis. Now, there are 9 type of glomerulonephritis primary. The many secondary are there, but important one are 2, 3. And hereditary, there are 4 types of hereditary. Out of all these, how many will result in nephritic syndrome? So these are the examples of nephritic syndrome. From primary, these are the examples, and from secondary, these are the examples. So total, we are having 9 primary. Out of the 9 primary, 5 are resulting in nephritic syndrome. Which 5? The first one, PSGN, right? PSGN. The second one, RPGN. RPGN. The third one, MCD is not there. MCD will be nephrotic syndrome. Then membranoproliferative, again, fourth one is not there. It will be nephrotic. Membranoproliferative glomerulonephritis and focal segmental. So these are the 4, 5-ness and IgA nephropathy you have to learn. These are the 5 you have to learn from primary, which results in nephritic. If you want to learn secondary also, you learn. If you don't want to learn, it's okay. Learn from primary. These are the examples of nephritic. Please learn. If you can learn all, it's good. If you can't learn all, please learn what is the most common cause of nephritic syndrome. Answer is RPGN. So RPGN is the most common cause of nephritic syndrome. Everyone give me a thumbs up. Everyone. I'm done with nephritic. Let me start with nephrotic. Then we will do a back-to-back comparison. Let me come with nephrotic syndrome. In nephrotic syndrome, a patient will come to you and complains of 6 things together. Not 5. 6 complaints given by the patient. What are the 6 complaints given by the patient? Number 1, there is no hematuria. Patient will not have blood in urine. Please understand, hematuria is a thing which differentiate nephritic and nephrotic. Hematuria is present in nephritic and it is absent in nephrotic. Please learn it crystal clear, right? So there is no hematuria. Proteinuria is present in both. Proteinuria is present, just a second. Yeah, proteinuria is present in both. But in nephritic syndrome, if you remember, their proteinuria was mild and non-selective. Here proteinuria is massive and selective. Selective proteinuria is there. Give me a thumbs up. Everyone give me a thumbs up. So, okay, how I should explain you. So, let me draw 2 kidneys. This is kidney. This is kidney. This is aorta. Let me draw aorta. This is renal artery. Renal artery. From renal artery, inside the kidney, okay, this is a nephron. Let me draw only one nephron. There are 1 million nephrons. Let me draw only one, right? One nephron here and one nephron here. Okay, so this is nephron. So this afferent arteriole, renal artery में से निकल के afferent arteriole is going here and efferent arteriole is coming out and ultimately urine is coming out of urethra, out of the body. This is the urine. So this is how whatever substances want to get excreted from the blood, it will be excreted into the kidney. What I want to explain you here, whatever protein present in the blood, okay, let me draw. This is the albumin present in the blood. Albumin present in the blood. So it will go in the kidney. So kidney normally do not filter albumin and excrete it in urine. Albumin is very costly, right? The people who do gymming, they ingest albumin separately, protein separately. It is very costly. So here the body, the kidneys are excreting albumin in urine. So whatever albumin present in blood, it will be excreted in urine. Protein is excreted. So there is massive proteinuria. The definition of massive is more than 3 gram per 24-hour urine. Massive proteinuria, and especially it is albumin. There are some other proteins also, but very minor amount, especially 99% it is albumin. That's why it is known as selective. Have you got it? Now, if all the albumin present in blood is excreted in urine, so blood will have less protein. So it is known as hypoalbuminemia. Blood will result in hypoalbuminemia. Have you got it? In blood, there is less albumin. So there is massive proteinuria because all the protein is excreted in urine. That's why blood have hypoalbuminemia. Hypoalbuminemia. Please understand the terms. It is urea. Protein is excreted in urine, or anemia. Mia means blood. So less albumin in blood. The two things are related. Give me a thumbs up first. If you got this, now you know what are the causes of edema? I have taught you edema in general pathology. So one of the cause, there are two type of pressures in the blood. Now hydrostatic pressure and second is oncotic or colloid pressure. Oncotic and colloid pressure is the pressure due to protein. Yes. Now here in this patient, there is less protein in the blood. All the albumin is already excreted. So less albumin. So less albumin, it cannot hold water. So all the water present here will move out because there is less albumin. Albumin hold water. Albumin hold water because of the oncotic or colloidal pressure. Now all the albumin is already out of the body. Protein is all out of the body in the urine. So blood do not have albumin, very less albumin. So there is no albumin to hold water. So all the water will go out and it will cause edema. So there is edema which is massive edema. But the reason for edema here is not sodium water retention. The main reason for it is sodium water retention, of course, thoda to wo bhi hai, but main reason here is decreased oncotic or colloidal pressure. Decreased oncotic pressure or colloidal pressure, that is decreased albumin. Decreased albumin, decreased protein is the reason for edema here. In nephritic syndrome, the reason for edema was sodium water retention and their edema was mild. Only on the face. Here edema is massive throughout the body. Throughout. So patient will have anasarca, throughout body edema swelling. Give me a thumbs up. That is the third thing patient will have. Everyone give me a thumbs up if you have understood these three things. Okay, let me come on other three. So patient will have massive proteinuria. Because of massive proteinuria, all the protein is excreted in the urine, especially albumin. So in the blood, patient will have less albumin. It is known as hypoalbuminemia. Give me a thumbs up. And all the albumin is excreted in urine. Blood will have less albumin. So patient will have edema, massive edema. The reason is decreased oncotic pressure or colloidal pressure. If you got these three, let me come on remaining three. Okay, how I should explain you. Listen, these are the two kidneys. Right. Okay. Again, this is aorta. These are the renal artery. So I am telling you, whatever albumin is present here, kidney is excreting all the albumin here in urine. So all the albumin is excreted in urine. So there is less protein in the blood now. So because of this, there is liver in the body. Liver synthesized protein. You know, liver synthesized protein. So liver want to do the feedback, the compensation. Now all the protein is excreted in the urine, so there is less protein in the blood. So liver want to do the compensation. So liver will increase the synthesis of the protein just to compensate it. Liver want to increase the synthesis of the protein. Now liver synthesize lipoprotein. You know lipoprotein, there are various lipoproteins, the carriers of the lipids, that is LDL, HDL, you know, chylomicrons. There are many lipoproteins are there. So that all are synthesized inside the liver. So for the sake of compensation, liver will increase the synthesis of lipoprotein, not actually protein, but lipoprotein. So lipid in the blood will be more. So patient will result in more lipid. Lipid in the blood will increase. Protein to nahi बढ़ा, lipoprotein बढ़ गया तो lipids का absorption बढ़ गया. So patient will have lipidemia, hyperlipidemia, more lipid in the blood. Give me a thumbs up. Lipidemia. Patient will result in lipidemia, more lipid. If you check the cholesterol, it is high. Triglyceride, it is high. Why? Because the lipoproteins LDL, HDL are high. Give me a thumbs up. All the lipid will go in the urine also. So patient have lipiduria also. So urine में भी lipid ज़्यादा है, blood में भी. So first lipid will come in blood and lipid will be excreted in urine. So lipiduria. Patient will have lipidemia and lipiduria both. So patient will have hyperlipidemia and hyperlipiduria. These are the next two findings in this patient. If you check the cholesterol in blood, it is more. If you check the cholesterol crystals in the urine, it is more. Give me a thumbs up. The last and the sixth is hypercoagulability. I will explain you the reason for this later on. But yeah, these are the hypercoagulability is the sixth feature. These are the 6 features present in a patient of nephrotic syndrome. Have you got it? Have you got it? Now I will explain you the reason for everything. The first is massive proteinuria. Massive means severe. Severe, more than 3 gram protein per 24 hours. And here it is selective. Mostly it is albumin, mostly. But some other proteins are also lost, right? And because most of the albumin is already excreted in urine, so in blood there is less albumin. So it is loss of hypoalbuminemia, loss of albumin and hypoalbuminemia, right? So AG ratio in the blood will reverse. You know, albumin globulin ratio will reverse because there is less albumin or relatively more globulin, right? So there is reversal of the ratio. Now you tell me, albumin to gaya. Albumin is lost. So 90% of the protein is albumin which is lost. But there are 10% other proteins also which are lost. So name the others. Others में क्या क्या है? Others में क्या क्या है? Others में globulin में immunoglobulin है. So immunoglobulin, there are 5 types of immunoglobulin, gamma, IgG, IgA, IgM, IgD, all will decrease. So patient will have less immunity. Patient will have more infection. So a patient with a nephrotic syndrome will result in frequent infection. This is the reason. Because the protein is lost by the kidney, one of the protein is immunoglobulin that is lost in the urine. So immunoglobulins are lost in the urine. Patient have less immunoglobulin or antibody in the blood, so infections are more. Give me a thumbs up. Name the most common infection in a patient with nephrotic syndrome. Can you name? It is the name of the infection. It is written in front of you, pneumococcus. The second most common is E. coli. So learn these two bacterial infection most commonly occurs in a patient with nephrotic syndrome. So your patient with nephrotic syndrome will have frequent these infection. The reason is in front of you. Number one. Number two, there is another protein which is known as antithrombin. Antithrombin. It is also lost in the urine. So patient have less antithrombin. Normally this antithrombin, as the name indicate, it inhibits thrombosis in blood. No, there is no antithrombin. So patient will result in hypercoagulability. I told you na hypercoagulability ka reason baad mein batati hu. This is the reason. Why patient? The sixth, there are 6 features of nephrotic syndrome. Now, what is the sixth one? The last one, it is hypercoagulability. Why the patient will have hypercoagulability? Because of loss of antithrombin in the urine. So, blood will have less antithrombin. Less antithrombin will result in hypercoagulability of blood. So, patient will have renal vein thrombosis or other hypercoagulability syndromes. Give me a thumbs up. The third is transferrin. Transferrin is also a protein. It is required for iron transport. So transferrin is lost in urine, less transferrin, so less iron, so patient will have anemia. Patient will have iron deficiency anemia. The fourth is cholecalciferol protein. It is required for vitamin D. So patient will have hypocalcemia. Next is thyroxine binding protein. It is required for transport of thyroid iron. So patient will have hypothyroidism. Patient will have hypothyroidism. The next is ceruloplasmin. It is required for calcium. For copper. So patient will have less copper. So imagine a patient having nephrotic syndrome, having more infection, having hypercoagulability, having anemia, having hypocalcemia, having hypothyroidism, having less copper in the blood. The reason for all these is different small amount of protein which are excreted in the urine along with albumin. I want a thumbs up. I want a thumbs up. So all these protein, can you name them? Can you name them? So the main is the albumin. The main is the albumin. Apart from albumin, it is immunoglobulin, it is transferrin, it is calciferol binding protein, it is thyroxine binding protein, and it is antithrombin. They are also excreted. So albumin is less. I agree. It will result in edema. Immunoglobulin is less, so it will result in infection. Transferrin is less. It result in iron deficiency anemia. Calciferol is less. It will result in less vitamin D, so hypocalcemia. Thyroid is less. Thyroxine binding protein, so it will result in hypothyroidism. Antithrombin is less, it will result in hypercoagulability. So a patient with nephrotic syndrome, these are the symptoms, various symptoms. Most common infection is pneumococcus followed by E. coli. You are not giving the thumbs up. All these protein decreases. See the arrow. They all decreases. Only one protein increase in nephrotic syndrome. Name that protein. Fibrinogen. Fibrinogen is increased. Fibrinogen is increased to compensate. Fibrinogen. So please learn your fibrinogen separately. Have you got it? So first is heavy proteinuria, second is hypoalbuminemia, third is edema. Edema is due to fall in colloid pressure or oncotic pressure, not due to sodium water retention. Fourth is hyperlipidemia, because liver is compensating the massive protein loss by forming lipoproteins, and lipoproteins will cause hyperlipidemia. The hyperlipidemia will result in lipiduria. So all the lipid will be excreted in the urine, lipiduria. It will leak in the glomerulus and lipiduria is there. And last is hypercoagulability. I have told you reason for hypercoagulability. Antithrombin is decreased and fibrinogen is increased. So I have told you this is the reason for hypercoagulability. So these are the causes or examples of nephrotic syndrome. So learn the primary. It is MCD, it is membranous, membranoproliferative, IgA. IgA दोनों जगह आ रहा है. If you want to learn all, learn all. If you don't want to learn all, learn the most common. So let me summarize. Now please everyone write down the summary. Please write down nephritic. I'm adding nephritic syndrome and nephrotic. I want your help to complete it. Tell me 5, 1, 2, 3, 4, 5 features here, and tell me 6. 1, 2, 3, 4, 5, 6 features here. Tell me the examples. Examples most common here and examples only most common here, not all. Who will help me? Sweetie, Rishinika, anyone else who's listening? Want to help me? Please help me. Please help me, guys. I've already taught you. So it is just for the sake of your revision. Who will tell me the features? In nephritic syndrome, patient will present with, number 1, it is hematuria, that is blood in urine. There is no hematuria in nephrotic. After that, proteinuria is there. Proteinuria, very good, sweetie. Proteinuria is present, but here it is mild and non-selective. You know the cutoff. When we called it as mild, when it is less than 3 gram per 24 hours. Here also we have proteinuria. Proteinuria, here also we have, but it is severe. It is severe and selective. Severe means more than 3 gram per 24 hours, right? And there is no hematuria in nephrotic syndrome, right? Here the third, what was the third? I forgot. It is hypertension. Patient will have hypertension. There is no hypertension in nephrotic. Patient will have edema. What is the reason for edema here? In nephritic, the reason for edema is sodium and water retention. The edema is sodium and water retention, and edema is mild here. Edema is mild here. There also we have edema. There also we have edema, but edema is severe there. Number one, it is severe. It is not mild. It is throughout the body. Here mild is only on face, around the eyes, periorbital edema. Here throughout the body patient will have edema, and reason for edema is less oncotic pressure. Very good, sweetie Rishinika. Very good. Less oncotic or colloid pressure. It is sodium water retention, less contributing. Main is less oncotic pressure. Have you got it? Have you got it? And last finding here. Last finding here, what was it? I forgot. What was the last finding in nephritic syndrome? The fifth one. What was the fifth finding in nephritic syndrome? Patient have hematuria, patient have proteinuria, patient have hypertension, patient have edema, patient have oliguria. What do you mean by oliguria? Less than 400 ml of urine per 24 hours. So these are the 5 features of nephritic syndrome. Patient will typically come to you. You will see a patient with these 5 features, right? Out of these 5, 2 are common. In nephritic and nephrotic, it is written in front of you. The 2 common. Proteinuria here also, here also. But in nephritic, it is mild and non-selective. In nephrotic, it is severe and selective. Edema here also, here also. But in nephritic, it is mild only on face due to sodium water retention. In nephrotic, it is severe throughout the body, and it is due to decreased oncotic pressure. Everyone give me a thumbs up. Very good, sweetie. Very good. Have you got it? Have you got it? What are the other 4? 2 to common ho gaye. What are the other 4 findings in nephritic? Let me finish nephritic. We are done with proteinuria. We are done with edema. What are the other 4 findings? So because of proteinuria, all the protein is excreted in urine. So there is hypoalbuminemia. So blood will have less albumin. Right, because the blood will have less albumin, liver will try to compensate it by synthesizing more protein. But liver cannot synthesize more protein, liver will synthesize more lipoprotein. So it will result in hyperlipidemia. Very good, Rishinika. And it will result in hyperlipiduria. Lipidemia and lipiduria, right? And last is hypercoagulability. I have told you the reason also. That is decrease antithrombin and increase fibrinogen. Give me a thumbs up, everyone. So these are the 5 and 6 features. So in nephritic syndrome, you have 5 features. In nephrotic, you have 6. Out of this 5 and 6, 2 are common. That is proteinuria and edema. Proteinuria and edema. But that is also somewhat different. I have told you the differences very clearly. Now tell me the example. What is the most common cause of nephritic syndrome? Answer is only one. RPGN. Please learn. What is the most common cause of nephrotic? No, there are 2 answers. If you talk about children, the answer is minimal change disease. And if you talk about adults, the answer is membranoproliferative glomerulonephritis. No, it is membranous glomerulonephritis. MCD and MGN. Please learn, please learn. Here there is no children and adult, it is always RPGN. So please learn it. Everyone give me a thumbs up. I want thumbs up from everyone. Rishinika, Sweetie and others also. Please everyone give me a thumbs up. That is the summary. What I have taught you in last half an hour. This is the summary. Everyone give me a thumbs up. Everyone. So that is the thing. So in adults, most common cause is membranous glomerulonephritis, and in children it is minimal change disease. That is about nephrotic syndrome. In nephritic, only RPGN is the cause. RPGN is the cause of nephritic syndrome. Have you got it? Have you got it? So see this table. Everyone see this table. Who will help me? Everyone see this table. Everyone. Nephritic, nephrotic. Here proteinuria is mild, 1 to 2 gram per day. Here it is severe, more than 3.5 gram per day. Here hematuria is present, but there it is absent. Here hypertension is present, there it is absent. Here oliguria is present, there it is absent. You know the meaning of azotemia? What do you mean by azotemia? Whenever patient have oliguria, so less than 400 ml of urine is coming out. Why human required to excrete urine? What is the reason why we should excrete urine? Why adequate urine? Because urine will excrete BUN, you know, blood, urea and nitrogen. That is the vestigial product in the blood. We want to excrete BUN in the blood. Now if the urine will be less, so BUN will be accumulated in the blood. So patient will have more uric acid and more creatinine and more nitrogen in the blood. These are the vestigial products. We do not want it in blood. So they will get accumulated and they will cause some symptoms. Those symptoms are known as azotemia. So oliguria will result in azotemia. Have you got it? So azotemia and oliguria both are features of nephritic. Coming on nephrotic, proteinuria तो common है. Edema is there. Edema भी दोनों में common आएगा. लेकिन यहाँ पे hypoalbuminemia, hyperlipidemia और lipiduria are the features of nephritic. So you got it. You can see this table also. Nephritic, nephrotic. Please see it clearly. Here proteinuria is mild. Here it is heavy. Less than 3 gram per 24 hour, more than 3 gram. Hypoalbuminemia is absent there, but present here. Edema is present in both, but here it is mild in loose tissue in the eyes. Here it is marked and present throughout the body, generalized. Mechanism of edema. Here mechanism of edema is sodium water retention, and here it is decreased oncotic pressure. A little bit sodium water retention will be there, but main is decreased oncotic pressure. What about hematuria? Hematuria is present here and absent here, right? Hematuria is a feature of nephritic, not nephrotic. Hypertension is also a feature of nephritic, not nephrotic. But lipidemia, lipiduria, these are features of nephrotic, not nephritic. Oliguria, again a feature of nephritic, not nephrotic. And hypercoagulability, again a feature of nephrotic, not nephritic. You know it clearly, I guess. So please everyone give me a thumbs up and appreciate my efforts. I have taught you nephritic and nephrotic syndrome very beautifully. Please appreciate my efforts. So with examples, with reasons, with the properties, you understood what is nephritic syndrome, what is nephrotic syndrome. We will do few polls. Hypercoagulation in nephritic syndrome is caused by. Why in nephrotic syndrome patient have hypercoagulation? The sixth property. Why? I have told you the reason. So does anyone know the reason? The 4 options are in front of you. Is it due to loss of antithrombin or decreased fibrinogen or decreased vitamin K or decreased protein C? I have told you albumin is lost in urine, but 90% of albumin protein is lost in urine, but 10% others are also lost. In others, one of them is antithrombin. Antithrombin is also lost in urine. So patient will have less antithrombin, and because of the less antithrombin, patient will result in hypercoagulation. This is the main reason. One more reason. I have told you all the protein is decreasing in the blood. Albumin is lost mainly. Apart from it, antithrombin is lost. Apart from it, transferrin is lost. Ceruloplasmin is lost, thyroxine is lost, calciferol is lost. These all are lost. Only one is increased in blood, that is fibrinogen. So not decreased. Here it should be increased fibrinogen. So 2 reasons for hypercoagulation. There are 2 reasons for hypercoagulation in nephrotic syndrome, not nephritic. Nephrotic syndrome, there are 2 reasons. What are the 2 reasons? Number 1, loss of antithrombin. Number 2, increased fibrinogen. Number 2, increased fibrinogen by the liver. Compensatory increased fibrinogen. Give me a thumbs up. I really tried hard. No one will explain you with such in-depth knowledge and crystal clear concept, right? So that is the thing. So here decrease की जगह अगर increase होता तो my answer will be B also. But here my answer is A. That is loss of antithrombin. Sweetie and Rishinika, both of you are right. Very good. Okay, coming to the next question. All of the following proteins are decreased in nephrotic syndrome except. So name one protein which increase. Rest all decreases. Only one protein in blood is increased in nephrotic syndrome because of compensation. So is it transferrin, fibrinogen, ceruloplasmin or albumin? I have told you very clearly. Rishinika, you are absolutely right. Very clearly. Yes, only one protein which is increased. What is that? Anyone else want to tell? Yes, it is fibrinogen which is increased. Transferrin is decreased. It results in anemia. Ceruloplasmin is decreased. It results in decreased copper. Albumin is decreased, it results in edema. But fibrinogen is increased in blood, which results in hypercoagulation. No, sweetie, it is not D, it is B. Sweetie, it is B. Fibrinogen is increased. Rest all are decreased. 90% protein is albumin. Rest 10% are these. Give me a thumbs up. Give me a thumbs up. Coming to the next question. Tell me the reason for edema in nephrotic, not in nephritic. Please mind my words. Tell me the reason for edema in nephrotic syndrome. What is the reason? Is it sodium water retention? Is it hypoalbuminemia? Is it increased venous pressure? Is it hyperlipidemia? What is the reason? Who will tell me? Who will tell me what is the reason for edema in nephrotic syndrome? Please be very clear in your concept. I'm asking nephrotic syndrome. Mind my words. Write your answer in the chat box. Rishinika, what is the answer? Yes. So yes, sweetie Rishinika, both of you are right. The reason here is this. It is hypoalbuminemia, that is decreased colloidal pressure, decreased oncotic pressure, right? I'm changing the question, Rishinika sweetie. Instead of nephrotic, I'm asking nephritic. What is your answer now? What is your answer from ABCD? The same options. What is your answer now? The same question with nephritic. What is your answer now? Yes, absolutely not. Right. Now your answer is sodium water retention. So if I ask in nephrotic syndrome, answer is decreased oncotic pressure or hypoalbuminemia. If I'm asking for nephritic syndrome, answer will be sodium water retention. Have you got it? Have you got it? Tell me the next question. Tell me the most common cause of nephrotic syndrome in adults. I'm asking in adults. Is it membranous glomerulonephritis? Is it MCD? Is it acute glomerulonephritis? Is it focal? What is your answer? Yes, you all are right. Very good. Your answer is membranous glomerulonephritis. And if I'm changing my question, instead of adults, I ask children, your answer will become B, minimal change disease. Have you got it? Yes, very good. Now, next question. The same question I have already asked. Answer is B here. Okay, so I am done with nephritic and nephrotic syndrome. Now I want to teach you the 9 type of glomerulonephritis, the primary glomerulonephritis. The 9 names are written in front of you. So I want you to make this table. I want you to make this table with me. The 9 type: APGN, RPGN, MCD, membranous, membranoproliferative, focal segmental glomerulonephritis, focal segmental glomerulosclerosis, IgA nephropathy or Berger disease, and chronic. These are 9. I will compare them in these headings: etiology, their gross, their 3 microscopy: light, electron, and immunofluorescence. And we will fill this table once for all. You will be able to complete all glomerulonephritis with me. Are you interested in doing so? Are you? Okay. We will definitely do it, but in the next lecture. My next lecture is just after 5 minutes, right? So give me a break for just 5-10 minutes and I will rejoin. So let me finish this this lecture. You people can go and after that rejoin the next one. Thank you very much for being with me for this lecture. I really enjoyed teaching you the nephritic and nephrotic syndrome. Hopefully same from your side. For the newcomers on Unacademy, we have 2 type of subscriptions. One is Plus and one is Iconic. In Plus, you will get access to live and recorded lectures of Unacademy only. In Iconic, along with Unacademy, you will get Prep Ladder also, right? And Unacademy have already launched NEET PG notes hard copy. So you can order your copy if you wish, the hard copy of the notes of all 19 subjects. Right, and these notes copy are free on 1 year and above subscription. If you are taking the subscription of 1 year and above, in Plus subscription, you will get free notes. The notes copy is free. So please take the advantage of this opportunity. Once you take the subscription, these are the batches. You can get access, the free access to all these batches you will get. These are the various prices of Plus and Iconic. You can notice, you can see all the plan. You can see one thing: longer the plan, cheaper it is. So according to your wish, need, requirement, you can purchase any plan, right? Whatever plan you purchase, if you apply my code SACHDEV10, you will get 10% discount before payment if you are applying my code. My code is SACHDEV, SACHDEV10. So if you are taking any Plus subscription which is more than 1 year, 1 year or more than 1 year, you will get notes free. You will get hard copy of the notes free. So you can grab this opportunity. Thank you very much. I'm having next lecture just after 10 minutes. Just after 10 minutes, give me a break of 10 minutes. Just after 10 minutes, join another link on the same YouTube channel. On the same YouTube channel, that is Future Doctors, I'm having the lecture of glomerulonephritis. I will teach you all glomerulonephritis after 10 minutes. So stay connected. I want everyone to come back, have a cup of tea, coffee, refresh yourself and come back after 10 minutes. We will continue the chapter. I'm stopping here.